then I'd like to call this meeting to order. Welcome everyone to the, oh God, I don't even know, February 9th, 2000
Recording in progress.
School Committee meeting. In keeping with an act relative to extending certain COVID-19 measures adopted during the state of emergency, signed into law by Governor Baker on June 16, 2021. This meeting will be conducted remotely over Zoom. Attendance by board members will be remote and attendance should count towards quorum. The meeting will be broadcast live on Facebook and recorded on ECAT. And I do just want to say that we do not, it's a one-item agenda. There is no public comment tonight. It's just for the purpose of a first reading on a policy. And I know that there was some community concern about not being able to ask questions about the DESE announcement today, but that is not an agenda item tonight, so we would not be able to address it anyway, but our next school committee meeting will be on February 17th. All right, so our agenda item, I'm going to toss to Chrissy about the return to play.
Sure. We have Dr. Bornstein with us this evening to kind of advise us on our return to play policy. Unfortunately, Bill Matthews is not able to attend. I think he had a different date on his agenda, so I apologize for that. But Dr. Bornstein is here and can advise us on how to proceed with a policy for return to play for any of our athletes.
Great. Did you want me to just start speaking, or?
So I'll just kind of update right now that Dr. Bornstein, myself, our trainer, and Bill Matthews met last Wednesday to look at the procedures that we have for return to play. I'm sure Dr. Bornstein will share with you that the Friday morning after our school committee meeting, the American Association of Pediatrics came out with new regulations and recommendations for their return to play policy. So we have incorporated that into the return to play procedures for Oliver Ames and Easton Middle School athletes. And we have some procedures in place. I know that we had discussed that this is sort of ever changing right now because we are learning more and more about the after effects of COVID. And that is something that to take into consideration as you proceed with the policy. If the policy is more vague so that we can potentially adapt it as the recommendations come out from the professionals. That's one thing to take into consideration. So I can turn it over to Dr. Bornstein and he will be able to provide that information for you.
Yes. So as promised, things changed, and they changed about 12 hours after we met last time. So we reached out to the schools to make them aware of some of the changing recommendations. With our group, we had, I had looked through all the scientific references and resources that were attached to the new guidelines to see if there was anything scientifically that had really come out that was very different. Truthfully, we didn't see a whole lot different. So I spoke with the head of the pediatric cardiology department at Mass General, just to kind of get their opinion on things. So they're feeling, so there were a couple of positive things. One was that, despite the increased number of cases in kids with Omicron, they did not see a proportionate increase in cardiac concerns coming through their clinics. So, his feeling was that, much as we felt about other aspects of Omicron, that the risk might be somewhat lower with Omicron than we were seeing with other ones, with the caveat that cardiac conditions can trail a little bit. But his feeling was that the newer regulations, which would shorten the duration of time between when one gets sick and when one can get a medical clearance exam, and also for milder asymptomatic patients, shorten the duration of the actual graduated return to play protocol that the trainers would utilize, seemed reasonable. And we didn't see any evidence to suggest otherwise. So when we met on Wednesday, we talked about how implementation for that would look and what some of the challenges or might be. Fundamentally, one of the things that changed is that it's not as much of a one-size-fits-all protocol now for kids. So it segregates out what the protocol would be for mild or asymptomatic cases differently from those who have moderate cases. And both in terms of the time frame between when they can start a graduated return to play protocol and also what that protocol looks like. So we had some discussions with the trainer about how the implementation would be. It does simplify the trainer's role in terms of what the return to play is. So that should make things a little bit easier. And then we talked a little bit about implementation, about different ways to do it in a way that's efficient for the school and for the trainer and for the athletic department that they were going to look into. So the new guidelines allow for a child who had mild or asymptomatic disease on day 6, as opposed to day 11, to get a medical clearance to allow to start a graduated return to play program, whether that's medical clearance just by a conversation or a telehealth visit or an in-person visit with a physician. We did point out that the return to play protocol still does not impact infectiousness, and the new guidelines are pretty clear and adamant that those who are returning to sports activity and physical activity between days 6 and 10 do need to wear a mask throughout that activity to avoid potential spread of the virus to other players. And we did talk a little bit about how this change affects clinicians who have to provide this clearance, because for many of us, we have segregated areas of our office for those who might be infectious with COVID versus those who are non-infectious, and so it required some of the offices to change protocols and change how they might be seeing patients, so that there may be a little bit of a lag time for offices to adjust, because they have to change the personnel and scheduling and those sorts of things for that. So there may be a little bit of lag for people caught in between, or conversely, people who may have had appointments scheduled for 11 days out now on sooner may not get one as quickly because the schedule's full. So just for families and the school to be aware that might happen. But I think overall this will be good for kids. It'll be good for the trainer, because I think it'll make it a little bit easier in many respects on her. It will make it a little tricky for the school just to make sure that there's some clarification coming from the physicians who are clearing the kids to return to play, what type, for lack of a better word, of COVID they had, to make sure that they fall into the correct protocol. So we tried to talk about the schools, making sure there's some clarity when the student comes in about whether they were asymptomatic, mild, or moderate. So we had that discussion as well. And then as far as policy, much like we talked about, it doesn't really make a lot of sense, because as data changes, the school needs to be able to respond flexibly and relatively quickly. It doesn't make a lot of sense to write what the current trees are in the protocol, but to make sure that the policy that's written is more of a forest picture, that because there is risk of cardiac involvement with COVID, that the school system will adopt a graduated return to play protocol as per guidance through through discussion with the medical consultants for the school system, and that changes may come about related to that, and that the team involved with the decision making involves the school administration, the trainers, the athletic department, the relevant, the school committee, the relevant partners in that. And that would hopefully avoid having to rewrite full policy every single time. So that's.
Go ahead, I'm sorry.
Well, that was pretty much the overview.
So Chrissy, are we still looking to make this a policy or to keep it as a protocol?
So I think that that's up to the school committee, which you would prefer. I again would defer to Dr. Bornstein. If they think that if I know that when we initiated our conversation at the beginning, we said you had recommended that it be a policy, Dr. Bornstein, but then leaving it vague for this purpose. But I'm not sure if it's necessary, like concussion, is there a concussion policy that the school committee has? I mean, this is something similar that that Dr. Bornstein was referring to, that there, if we look at it similar to the way that the concussion policy was.
Are there any school committee questions, Caroline?
We do have a concussion policy, but we also have guidelines that are attached to that policy, right? Or am I misremembering?
I'm gonna see if I can find it
Yes, I apologize.
online.
I should have pulled it up myself.
I'm thinking maybe this could be analogous to the face covering policy that we put in, which was broad, but then we had guidelines that were more specific, anticipating that those could change. And
Right.
that I think the structure around changing the guidelines was more flexible and fast than changing a policy, if I recall that correctly.
Yes, I think you're right. And I think maybe it does make sense to have a sort of vague policy about infectious diseases in general, or, from what we're reading, unfortunately, we probably need to be prepared for future pandemics. So it could just be something to the effect of, that protocols will be put in place, depending on the nature of the threat, or whatever you want to call it, the advice from the local public health department, et cetera, some sort of vague and then we could put the specifics. Those could be changed. The guidelines could be changed very easily. I don't know. I think it's not a bad idea to say that we at least have a policy that says we will address a widespread viral threat in our community, but that the specifics could be variable. Go ahead, Jen, sorry.
Yeah, so looking at the what I could find from what's the manual that's posted online, there is an extensive concussion policy that it's like 7 pages.
Right.
So that gets into really everything, but that is something that's fairly stable, right? I mean,
Right.
yeah, we don't expect, emerging
going to say that.
concussion stuff to happen, within short order versus, so I think this is different, but so I think it would be, as they're saying, I think it would just be consistent to have a policy broad and then refer to the guidelines or, some document somewhere so that people have a specific written source to go to that gets updated time to time as needed.
I think the concussion policy was developed primarily from what the Mass Association of School Committees model policy was. I think we maybe did tweak it a bit, but and I don't know that we're looking to that organization at this point for a similar policy related to, infectious diseases or something like that. I don't know how we want to frame it, but it does make sense to have a very broad policy, I think, and then we can narrow down the specifics, the changing specifics.
Jackie?
Thank you, Dr. Bornstein, for being here. I do have a couple follow-up questions, but I just wanted to respond to something that Caroline said. The only concern I have about having a broad policy that says something like, we may have protocols to deal with infectious, we have flu, we have all kinds of things, and we're not dealing with those. So I don't know if right now, if we want to make that leap, if we want to just leave it more COVID specific and still keep it broad, but not kind of bring in any other potential infection. Because I I just think we're going out too much if we do that, but I'm kind of
No,
curious
I
to hear
think
what
that
people
makes sense. That makes
think.
sense. Yeah.
But
I think that-
I'm sorry, go ahead, Caroline.
No, I agree. Thank you for pointing that out.
So Dr. Bornstein, I just have a couple of clarifying questions, because I know you had mentioned that the American Academy of Pediatrics had changed their guidelines, and thank you for sending those to us, Chrissy. So, all right, so it was 10 days, and now they're saying 5 days from either a positive test or symptom onset, you can potentially get a clearance letter from your physician to go back, and then depending on what kind of symptoms you had, whether you go back to a return to play, how that works, how that's structured. Is that correct?
The earliest one would be able to go back would be on what would be considered day 6.
Day 6, okay.
So, and that is also dependent not just simply on you having had milder asymptomatic disease, it also means your symptoms are basically gone. To read
Okay.
the guidelines, with the
Yep.
exception of loss of taste or smell, which take a long time to recover.
Okay.
So not every child who's got mild disease may be ready to start a return to play. That's where the
Sure.
discretion. That's where the discretion of the physician
From
will
the
come into play.
pediatrician, okay. And so then
If
for
I could
children,
just, I'm sorry,
go
if I
ahead,
could just
Chrissy.
add that day 6 is also in alignment with the day that they return to school.
Okay.
Could be a
And so
return.
would they need, I know this is geared toward athletics, but so if they came back on day 6, to go back to PE, would they need any kind of clearance, or do they just go back to PE?
So we had some discussion around that at our meeting, because phys ed class is different than high school or middle school sports. It's a shorter duration. The intensity is much lower. And in discussion with the trainer and with Mr. Matthews, the feeling is that gym class, the level of intensity of gym class is probably equivalent to what would be the first step in the return to play protocol anyways, which is kind of like
Okay.
cardio. So the feeling was probably don't need a return to play for gym class, because there's not the intensity or the duration of activity in that class that it would be in a after school practice, for instance.
Okay,
I
thank
believe
you.
that's everyone's comfort level with that.
And I know during our last meeting, people raised a lot of questions about why are we doing this with COVID? We didn't do it with flu. We didn't do it with strep. I thought the way you answered it, it really gave me a lot of very good information. It was very helpful. So I was just wondering, for people that maybe missed the last meeting, that might look back on this very specific meeting, if you could just explain why it's different with COVID than maybe flu or strep.
Yeah, I mean, there's a couple differences. So, one is just the identification of the problem. So the frequency of the problem, the estimated frequency by which it occurs in kids with COVID is higher than it would be with a lot of other illnesses. And then the sheer numbers of kids who got COVID is the other thing. We generally don't get flu outbreaks where you're getting hundreds of kids a week getting flu simultaneously. So, so the likelihood of having a kid run into a problem on the ball field or on the court is much higher, which is why the surveillance recommendations and their guidance was put into place, both by not just by the American Academy of Pediatrics, but the sports medicine groups, the trainer groups, etc. So that's some specifics to it. And like I said, that one of the things that's still unknown because of just the timing of everything is, will Omicron be different than prior waves? Because most of the data came out of prior waves, came out of Beta and Delta waves, and the behavior of those viruses is a little different than Omicron. And because a lot of cardiac issues can be delayed, several weeks afterward, you're not going to see data coming that would be more Omicron specific probably for another couple months at least. So in the meantime, you work off the data you have.
Okay.
So that's the main distinction.
Thank you. And my last question is the governor lifting the mask mandate by the end of this month. I know this this protocol calls for students masking for those 5 days that they come back. after they've been out. You have any suggestions on what to do with that?
No, I haven't, in fairness, I have not heard or seen or read what the full statement was. I was driving the car and I just heard a little quick blurb on the news that we're going to let the state mandate and leave it up to local municipalities or local school systems to make decisions. So good luck with that one, right?
Thanks. Okay.
I can jump in on that a little bit because I did attend a webinar today at 1 o'clock on this, and they're actually shifting to not utilizing the term no masks, but less masks.
Okay.
And so there will be instances where they are recommending masks. For example, the health offices are considered medical facilities. So so everyone entering the nurse's office should be wearing a mask. And they did also say those that come back from quarantine should be still wearing a mask until that 10-day.
Okay, so that's consistent
DESE
with this.
Yeah, that is consistent. And DESE
great.
is coming out with, the Department of Education is coming out with more guidance on that within the next few days.
Christy, when you say
Thank you.
they, who's they?
I'm sorry, DESE, the Department of Education, are coming out with more FAQs around certain scenarios. So we had a COVID testing webinar today at 1 o'clock, and Russell Johnston, who is from the Department of Education, he's kind of taking the lead on a lot of this and providing information in consultation, obviously, with their team. They have a lot of medical experts on their team. And he did say that there will be, I like that terminology. It's not no masks, it's less masks.
Okay.
And he said that will be coming out. There are some slides that were presented that I can share with all of you on that. But I do think that does coincide with the return to play policy.
No, that's great. That clarifies that for me. Thank you so much.
I have a question, and I apologize if you answered this. In the return to play phase, model A and B, who is monitoring and deciding this when a student would transfer between stage 1, 2, 3, or 4?
So that was something we discussed because again, given the timing and the density of cases,
Yeah.
you can't have a trainer overseeing individual, 150 individuals simultaneously. Like they can't clone themselves that way. So that was something that she and Mr. Matthews were going to try to work out. So one model would be if you have a group of kids who are on day 1, for instance, of return, can you do them as a group? Can you work them out together for 15 minutes, supervise them together, check them off? So you're doing like a group visit. That would be one way to potentially do it. The other question, and this was going back a little bit to the kind of legal allowances and stuff, is sport specific issues, right? So a swimmer demands are different, for instance, than someone who does winter track and like doing field events. Like the cardiovascular demand on someone throwing a javelin is very different than someone who's swimming, as an example. And so, and you can't be on the field and in the pool, the trainer can't be at the pool and in the field at the same time. So, the question was, is there a way to delegate some of this, or is it allowable to delegate some of this to a coach or an assistant coach to oversee or not? That again ends up being a little bit of a legal question. But that would be another potential option if that's allowable to do that, where the trainer could basically write out for the basketball coach or the swimming coach and say, if you have someone step 1, this is what you're going to do with them for their exercise, and you're going to monitor for this, and then we'll check them off. And for step 2, it would be this. And the trainer could help to, a sports.
Potentially the person who's making these decisions doesn't have a medical background.
Well, that's where the delegation question comes in. So for instance, on a separate way, right? The school nurse is allowed to, in certain situations, delegate a non-medical person to administer medication. But it requires, the state requires training of that person, oversight, there's protocols, and there's limits to what you can do. I don't know if a similar thing exists in the setting of athletic trainers or not. So that, I mean, that was the core question there. And I think the trainer was going to try to figure that out. Bill, I think, was going to try to figure that out. The school administrators were going to try to figure it out. So in theory, it might work. Whether it's an acceptable option is not, I don't know the answer to that one.
Chrissy, would we have those answers prior to a second reading?
Yes, and one of the things too I want to point out, because I have my notes now in front of me, that Cassidy, our trainer, actually talked about how most, if not all, of the cases that she has seen have fallen currently in the mild range. So that's just a statistic that's important, I think. So most of our students, our student athletes, would fall into the less severe return to play. And then we also did talk about as far as the policy goes at the school committee, it might be a good place to clarify who does the medical clearance and who does not do the medical clearance. So for example, the doctor, an athlete's pediatrician or a nurse practitioner would be able to do the medical clearance, but the athletic trainer cannot do the medical clearance.
It was very important to be very clear that medical clearance has to come from a physician, a nurse practitioner, a PA. It's basically someone outside the school system.
Right.
And then the graduate return to play is that's what the school system does, is that process, or the school personnel does.
Right. And the other thing to remember is the concussion policy. There's a lot more information on concussions right now. So I feel that is a longer policy because there is much more research behind that. So being able to give us a policy where that's not locking us into a return to play procedure, I think would be very beneficial right now as we're learning more about the ailments from COVID. And it's changing, consistently. What's coming out from the medical fields. So Michelle, I'm sorry, you're looking for having answers to what in particular?
Well, I'm just nervous that these kids are out on the lacrosse field or the football field or the tennis court or whatever sport that is. That one trainer you just said can't possibly be in all those places. So who, if we're putting this into effect to protect children, who is actually qualified to be watching that child or that athlete and decide, if the student saying, I don't have chest tightness or palpitations or whatever, and they're self-reporting, like who's making that decision to move them along? I don't know.
So just to give you a little reassurance on that, in truth, the coaches themselves have the best sense of what the student's fitness level is at baseline, right? So take into example your sprinter on the track team, right? So to some extent, right, some of the cardiac things, what the impact is going to be on performance and stamina. If you're the basketball coach and you see your star basketball player like huffing and puffing after one or two times off the court, which is not typical for that person, the coach is probably going to see it almost more so than someone from the outside, because they know how that student normally runs and plays and what they're capable of. So, I think from an observational standpoint, outside, there's a rationale to have the coaches involved in that and to be aware of that. There's always going to be some degree of self-reporting, much in the same way that there is with concussion, right? You can't see a concussion looking at someone. You do rely on that athlete reporting that they're getting headachy or feeling nauseous, but you can't see nausea, you can't see a headache. So whether it's the trainer or the coach in that saying, they can't be held accountable for things they cannot see. In this setting, the things that would be things you cannot see would be, a sense of palpitations or regular heartbeats. That's going to have to be self-reported. But you can see someone who's got impaired stamina to a degree. You certainly can see someone who seems to be having difficulty breathing. And you certainly can see if someone's grabbing at their chest like they're having pain. So you're not entirely reliant in that setting on self-report. And obviously, if the kid's looking faint or woozy, that's a visible sign. So I'm not, like, just from an observational standpoint, I'm not super worried about the coach's ability to detect that. Other than that, they have to be focused a little bit on it. I mean, the advantage of having a trainer there is that trainer's only looking at one player. They're not looking at how the team's playing as a whole. So, to some extent, the role has to be like either before practice, you take that kid aside and you have them do some things, or you do something in a very small group where you can really observe the kid for a period of time. Or the assistant coach's job is to do that, if there's an assistant coach, for instance. So I think it's a doable thing. I think it's still a question of, is it an allowable thing from like a risk management standpoint legally? But I don't think it's irrational to do it that way, because I do think the coaches know their players.
Thank you. Are there any other questions? Caroline?
I'm just wondering if that would actually be a question for our attorney. I mean, Dr. Bornstein, what you say makes perfect sense, and I agree. It seems absolutely logical that the coaches would have the best sense of whether or not a child was struggling. But I think we'd probably want to run that by our attorney, just to make sure that we weren't creating expectations for coaches that honestly could get them in trouble if they missed something.
I don't want to create exposure where it shouldn't be.
Right.
Yep, I have that written down for Rebecca, just to say who is qualified to monitor the return to play, but what are the what's the risk management behind that?
Thank you.
Right. If delegation would create any kind of legal risk,
Right.
either for the district or for the individual coaches. Yeah.
Anyone else? Jen?
Chrissy, do we know, or if this came up in conversation, Dr. Bornstein, with the athletic director? I guess it wouldn't. We wouldn't know right now because they should be following the return to play protocol. I was wondering, so swim and dive, those are the two sports where you literally cannot wear a mask. So under this guidance, are they allowed to return to the pool on day 6 to start training? Like, you can't wear a mask. So would that be the one thing? Do we need to put something in either in this guidance or the policy that states, that just ties this to following any masking protocols that may also be in place? And then that way, I really think that's probably the only sport I can think of where a student wouldn't be able to participate before day 11 because they are supposed to be fully masked through day 10, even if they're coming back from asymptomatic and are feeling fine.
Yeah, that's a great question. We didn't actually address that specific question. We did adjust swimming as the highest risk sport. Because if someone has a cardiac event, you're in a pool, you can drown. So we did talk about like how to be a little bit particularly cautious around swimming just because of that reason. But we didn't talk about the masking part. I mean, part of me is like, when you're in the pool and in the water, your ability to spread, because your mouth is not in the air much.
Yep.
Right.
Probably not an issue while you're in the pool and swimming, but when you get out, you would need to mask.
Yeah, because they do hang out together on the pool
question.
deck.
Yeah.
And that might have been something.
It's in the AAP.
It might have been, was it in the AAP?
Yeah,
Yeah,
it's
the
in.
AAP
They
addressed
go
it,
through
right?
all when you should wear a mask, when you can't. They do go through that.
Okay.
Yeah, I actually was wondering if we should have as part of the policy, attending to the AAP guidelines. I thought those were pretty good guidelines in terms of the, differentiating among the sports, indoor, outdoor, et cetera.
you certainly, like, you can, but what's going to happen over time is you are going to get some discrepancies between guidelines, if for no other reason that committees meet on a schedule. And so the AP schedule may not be the same as the American Heart Association schedule or the sports medicine. And then if you're sticking to one and something changes somewhere else, you might agree with the other one, you're kind of a little bit stuck. So it's not a terrible idea. And the reality is a lot of these groups have some degree of overlap, right? So like the American Academy of Pediatrics consults with pediatric specialists, the orthopedists, the sports medicine folks as well within their own organization. But you know, I think to some extent, like our role is to help parse all this information for you a little bit, and then help you help guide you about where you might want to go with it. So it's, yeah,
That's an
it's fine,
excellent
but
point. Yeah, no, that
Yeah.
really is an excellent point, because some of the, you know, perfectly respectable organizations that are addressing COVID issues haven't been exactly in sync, and that's confusing for everyone. So that is actually an excellent point, that if we were to rely on one particular source, that could be a problem.
no, and a lot of it has to do with scheduling. Like these committee groups will meet on a periodic
Right.
basis. So like, you know, you're not going to get something interim in between.
That's why we have you here to point out those excellent issues. So thank you.
Any other questions?
Well, how do we actually frame the policy? I mean, how do we move forward on however broad or vague we want to make it? We do need to come up with actual language. So how, I mean, essentially, we probably can't even really consider this it wouldn't be considered a first reading, right? Because we don't have a policy yet. So,
Well, why
is
wouldn't
this
this
the policy?
protocol be the policy?
okay, the protocol you would say would become the policy then. Okay.
Well,
I
the
mean,
I thought,
it's pretty vague, isn't it?
What are you which one are you referencing?
The
I
one-
have the go ahead.
The February 3rd one that you sent to us.
The participation in extracurricular athletic activities. That one?
No, it
No,
reads,
the return to, it says COVID-19 return to play protocol, February 3rd, 2022.
Yes. Yes.
One page.
One page. I mean, this wasn't intended to be the policy?
This is what Bill sends out. The one that Rebecca wrote for us was the participation that was given to you at the last school committee meeting.
Okay, so the one you sent us two attachments, one that said
Yes.
COVID-19 return to play protocol, and then the clearance form for the physician to fill out.
Yes.
So this was not meant to be the policy?
It's what the, it's not that it was not necessarily meant to be the policy, because that is what that's the protocol that Bill Matthews is using. So I
Okay.
don't know if it's worded to be a policy is my point.
I thought,
Yeah, I
I
think-
think that we were under the impression that the policy that you sent us just before the last meeting was going to be tweaked that
Right.
next day, and we were going to get an updated version. But now I'm hearing you say there is no updated version. Is that correct?
That is correct.
Okay, so then Carolyn's right. We can't have a first reading if we don't have a policy.
Okay.
Okay.
Yeah,
think
so
we
because
all
the
thought that
policy-
this was what you changed it to.
Yeah,
the policy draft that was circulated on the 28th does have a lot, it's very granular. So I think the
Right.
framework is there to maybe strip out a lot of the specifics
Yes.
and just reference the return to play protocol, similar to the face coverings and then all the face covering detail and any others that are structured that way. But yeah, you're right. So we can't
I
do the
didn't go
first
back and
reading.
look at it because I
as
thought we were
is.
getting an updated version. And
I mean, I don't mind taking a crack at updating this, or I don't know if Jackie, I know you've written and edited a lot of these. I don't know if somebody else wants to.
You're very welcome to do it. I'm happy to help.
Okay.
But yeah, if you want to do it. Nancy, unless you want to do it.
I
Or
can,
anybody else.
My
Anybody else?
policy co-chair.
I know,
I'm
really.
sorry.
But looking at the one that we got in January, I mean, it's pretty broad and there's a lot of, information in it. But I think we could take that, the one that we got today and just kind of adjust it from, because on this first one we got, there's a day 7 return and there's a day, I don't know, there's a minimum of this and a maximum of that, or whatever. We could just kind of, like Jen, I think, or whatever. I mean, I'm not really good at it, but it would just seem to me, just taking the new stuff from their meeting and putting it into what Rebecca wrote.
right. So if you look at what Rebecca had provided, or Rebecca's office had provided for us, the first two, I don't know if you have it in front of you, but the first 2 paragraphs seem very,
They're general.
Legal.
And the bulleted points get into very, detailed, specific. I would suggest we take that out
Right.
because that is too detailed. So basically the remainder of the document, and instead supplement some of the information from the protocol. So what I had shared with you, it does say at the top that this is the protocol that is used by the Easton Public School Athletics. So that is what I was sharing with you, because the policy I misunderstood. I apologize. I thought that this was a workshop to discuss what would be involved in the policy. And then I would take that to Rebecca to have her revise it. Because I know that we couldn't discuss the policy unless we had a school committee meeting. So, probably essentially the workshop should not have had first reading in parentheses next to it. It should have been just to gather information so that I can then take it to Rebecca. And then the first reading would be, because I know that we have, the questions about, who's qualified to monitor the RTP. And those are things that can be embedded in the policy. But we would need Rebecca's blessing on that, I think.
Okay. All right. So then if the plan was to circle back with Rebecca anyway, if you
Yes.
maybe want to communicate that plan to her, and I think
Exactly.
certainly we can let her office,
Yes.
modify the draft policy to suit how we want it to work, and then reference the protocol.
And I know
Yes.
you're kind of in not a rush, but you want to get this done as soon as possible. So maybe we could try to have the first reading at the next meeting. Do you think, does that
Yes.
sound practical? And then we could even add a really quick workshop after that to have our second reading, because it sounds
Okay.
like we've pretty much gotten all the answers to the questions other than the legal stuff.
Sure.
So I don't know how other people feel.
So have so Jen and somebody is going to do some tweaks based on our conversation. I just want to make sure I'm understanding. And then we're going to do, and maybe get that to us ahead of time. And then we'll do a
Mhm.
first reading on the 17th.
Yep.
And then set up a workshop to do a second reading and a vote.
I will just say that I do feel confident after our meeting with Dr. Bornstein, correct me if I'm wrong, I do feel confident that we have a good procedure in place with Bill Matthews and Cassidy. So I don't know if there's necessarily a need to rush the policy. I do feel confident that if we had the first reading at the next meeting, which is next Thursday, and then the second reading on March 10th, I think that would be okay. I don't think we need to squeeze a meeting in there. just
That's
because
fine
I
with
think,
me. But when I mentioned that once to Dr. Cabral, she said March 10th was very far away. So I don't know if you want to double check.
okay,
So then I guess, Chrissy, if whenever you hear back from Rebecca, if you could just pass that information on to either Jen, if Jen wants to do it, or me, or both of us, or whatever, and then that can be incorporated. So we can try to incorporate that before,
before next week. Yep.
yeah, exactly. Thank you.
Looking at the January 28th document, really much of it is what we would call the guidelines. I mean, we would, and so it's the first two paragraphs are good, and then something about the parent's responsibility, which is later, would also be a good thing to have in the policy. But I don't think you need a whole lot more than that, as long as we can just tweak the guidelines a little bit, and we can be working on those without the first, second reading constraints and things like that. Anyway, just a thought.
Do you, now the guidelines, would you be the ones to look at that, or I'm sorry, adapt that, or would you leave that to Bill and Cassidy and Dr. Bornstein? Would you approve that?
We have approved guidelines in the past. They've mostly been recommended by basically Leisha or, the superintendent, obviously in collaboration with whoever else would be involved, like the athletic director, the music director, whoever. So I think we still approve it. I'm trying to remember if we actually vote, if we just sort of, by consensus, agree that it's appropriate. But I think we actually have voted in the past on guidelines as well as actual policies. But most of this, I mean, really those first couple of paragraphs plus something about the parental responsibility and so on is probably enough for an actual policy, as long as we can get some of those specifics, which a lot of those are in the still in the AAP document, the more recent one. So, okay, just struggling here.
All right. So is everyone okay then with, Chrissy's going to check with Rebecca on our questions. Chrissy's going to get that information to Jen and Jackie, who are going to revise a version of a draft and get it to us ahead of next Thursday. And then we'll do our first reading on Thursday. And then depending on what Dr. Cabral says about whether we need to do a second reading before the 10th, we'll set another meeting or not, because you're feeling like at least there's a good policy or protocol in place that's up and working.
Yes.
Does everyone agree to that?
Yep.
All right.
Yep. And Chrissy, I can, if it's easier than trying to explain the document to her, I'll do a quick markup of it, and then you can send that over, and hopefully that'll help.
No, I feel comfortable explaining it to Rebecca as well.
Okay. All right.
All right. Any last questions or comments before we adjourn? No?
Well, I'd just like to again thank Dr. Bornstein, who's been extremely patient during this process and incredibly helpful. So thanks again.
Very
Erin.
accessible. Thank you.
Great.
for
Thank you.
time out of your day.
No
Several
problem.
times. Wonderful. All right. So our next meeting is February 17th at 5 o'clock. Do I have a motion to adjourn?
O'Neill,
Star,
so
so
moved.
moved. Star
O'Neill,
second.
Darn. Okay, whoever records this meeting can take their pick.
Well, names out of a hat. All right. Roll call vote.
O'Neill, yes.
Durance, yes.
Luca, yes.
Wiseman, yes.
Star, yes.
All right. Thank you, guys. Have a good night. And again, thank you, Dr. Bornstein.